Hi everyone, and thank you for joining us for this webinar this afternoon. The webinar is on the reflections on public health system responses during COVID-19 in low and middle income countries. And we're being hosted by the Interdisciplinary Global Development Center, IGDC, at the University of York. My name is Jessica Mkuti, and I'm one of the postdocs at the IGDC. And I will take the next few minutes to just introduce you to IGDC and also to introduce our host for the session. IGDC is an interdisciplinary learning and research community for equitable global development, and we are based at the University of York. IGDC undertakes interdisciplinary research with a particular focus on social justice, global health, and sustainable environments. We also offer undergraduate and postgraduate academic programs in global development. The center itself brings together researchers from across the humanities and social and natural sciences, and within the University of York and globally. And we encourage researchers to work with one another and with policymakers and practitioners to address pressing global development challenges. Today's webinar is the fifth in IGDC's COVID-19 webinar series. The series explores different facets of the pandemic and how they relate to policy and research needs in global development. And the series features invited speakers who present case studies from across the world to reflect on the impact from and responses to the pandemic. And we will be asking, within the series, we will be asking how global development researchers can contribute to a better understanding of the impacts of COVID-19 and how these impacts can be reduced for this pandemic and for future pandemics. Now, I'd like to introduce our chair for today's webinar. Our chair is Dr. Papia Mazumdar, and she is a geographer and a population scientist for the Department of Health at the University of York. Her research focuses on environmental linkages to population health, and her work has spanned across health system responses to natural disasters and other concerns, including socioeconomic vulnerabilities of populations in low and middle income countries. And at the moment, she is a research fellow with the Mental Health and Addiction Research Group, which is MHARJ, which is based within the Department of Health Sciences at the University of York. And she is working on different aspects of mental health in South Asia. And so I'll just hand over to Papia.
Thank you very much, Jessica, for this kind introduction and setting up the stage for today's webinar. And we are also working with Tara, not to forget, because she's the technical help with this webinar. And thank you for supporting this, Tara. And it's time for the poll. And I will request Tara to understand where we are all from. This is the first poll that you can see in your screen. And so please mention that from where you are, just it's about the country, and then submit. And we have the results right after this. Okay, so I think of these 28 participants, we are mostly from Europe, I guess from UK, and University of York participants. I guess that some of the other participants will join us soon. Tara, thank you with this. And can you just put on the second poll? And we are having institutional affiliation in the next poll. You can see that 83% of our participants are from academic institutions, and there are certain numbers who are from private sector and others, which is not specified. Thank you for being with us today, all of you. And it's been a great pleasure joining you in this interesting topic of reflections from health systems responses in LMIC's context. So, so for today's COVID-19 webinar series organized by the Interdisciplinary Global Development Center at the University of York, we are reviewing the experience and lessons from the public health system's responses in the time of COVID-19 in the low and middle income countries. We have here with us today 3 excellent speakers and panelists across 3 different countries. And they will discuss on the issues, pertinent issues in 3 different LMIC contexts from Asia and Latin America. To briefly introduce their illustrious profiles, I start with Professor Achin Chakrabarti, who is a professor at the professor of economics and currently is the director of Institute of Development Studies in Kolkata. He's a PhD in economics from University of California, Riverside, USA. Professor Chakrabarti has research interest in development economies, especially the economies of the social sector and political economy of India. He's been kind of widely published in the high impact journals of development economies. He has 2 recent publications along with Professor Anthony de Costa, and this includes the title like the Land Questions in India, State Dispossession and Capitalist Transition, and Changing Contest and Shifting Roles of Indian States, very pertinent for development issues in India contemporary. Our next speaker is Dr. Daniel Mercera, is an Argentine citizen, PhD in economics from Boston University. Dr. Mercera is a professor at the economics department, National University of Buenos Aires, Argentina. He's a senior researcher at the Center for the Study of State and Society, CEDES, and director of the Health Policy Department at Foundation for Argentine Development. He holds a number of high-level positions in academic as well as policy forums in Argentina and internationally, including his serving at the present moment until October 2024 at the key roles of chair for the executive board members of Health Systems Global for the Americas. Our third speaker today is Dr. Riyam Hamoudeh, is an assistant professor at the Institute of Community and Public Health. She holds a PhD and MA in sociology from Brown University, USA, and MPH from Birzeit University, Palestine. Her academic interest lies in understanding how political and social transformations impact health, psychological well-being, and population processes, particularly in conflict-stricken areas, and the overall issues of health systems and social institutions development and shift in relation to political, economic, and structural factors. So thank you all for joining in today. And now, without wasting any more time, I will request Professor Achin Chakrabarti to present his thoughts on Indian issues. The floor is all for you, Professor Chakrabarti. And just a request for the audience, as Jessica has already mentioned, please put your questions while you're listening to Professor Chakrabarti's presentation in the Q&A box, and we get back to you after all presentations are over. Thank you.
Thank you, Papia. And let me thank IGDC, University of York, for inviting me to join this panel, very important panel on health system responses in the low and middle income countries. In my presentation, in the next 10 to 12 minutes, I'll focus on India. Let me summarize the main features which are being talked about in the context of India. The first very important feature is that India went for a nationwide lockdown, very severe lockdown, at a relatively early stage of its detection. Early stage meaning, when the number of cases was very small, very little, towards the end of March, the 4th of March to be precise, lockdown started in India. And lockdown meaning, everything actually stopped. All the economic activities, in fact, came to a stop. And there are serious repercussions of that, which if I have time, I'll come back to that. So this is the first feature, that India went for a very strict lockdown at a relatively early stage of the pandemic. The second is that, of course, I mean, we got some benefits of that severe lockdown at the beginning. It slowed down transmission somewhat, but later on, in fact, it continued. Transmission and infection rate continued to increase. And for several months, in fact, till September, we couldn't see that the infection curve actually flattening. Precisely in the next, particularly in the around the middle of September, we found that the infection curve actually reached its peak, and after that, in fact, it started, sliding down a little bit. I'll come to the next slide to show you the picture of that. Third point that I would like to mention in this context is that, of course, the lockdown pushed India towards its first economic contraction in over 4 decades. I mean, this is the first economic contraction, and that contraction actually, it is considered to be the severest among all the countries. The recent, all the forecasts about the growth rate for 2020-21, the recent IMF forecast actually says that the growth rate would be negative 10.5%. So this, this contraction, this severe contraction, actually, it is by far the severest, I think, among all the countries in the world. So you could see that we have already experienced the kind of worst of both worlds, in the sense that the infection curve actually still continued to rise, and at the same time we have already experienced a very severe economic contraction. Now, so we have to deal with both these issues together, as we move along. So I think that India's problem, if you look at the numbers, I'll show the numbers in the next slide. The next slide, please. Next one. If you look at these numbers, I just picked up only 3 countries, from the top. US, obviously, and India, in terms of number of cases, total cumulative number of cases, India is very close to US now, so it's the second highest, and India shares 17.8% of total cases globally, and the number of deaths, in fact, it's not that high compared to US, and on which I'll say a few things later. So the share of deaths actually 10.2, whereas the share of cases is 17.8. Now that looks slightly, better in terms of fatality rate. And when we come to this cases per million, because India is a huge country in terms of population, so if you divide by the population, then the number of cases actually would be far less than in case of US or Brazil. So these are the I mean, that is how we place the numbers here, because that gives you a sense of, I mean, this is the latest number as of November 2 from this WHO coronavirus dashboard. I just picked up these numbers. So that gives you the perspective that where India actually stands in terms of infection rate and the fatality rate. And next, please. So these are the figures for new cases and new deaths every day. I mean, it's the daily records, and you could see that that the peak actually is somewhere in September between 15 and 19. Around that time the peak reached, and similarly, similar is the case for new deaths also, that it reached the peak around mid September. So, but you see that throughout this, I mean, starting from March and then to September, it's steadily increased, and every day actually it kept on increasing. So, for these 4 months, in fact, we had absolutely no clue how to control these surge in numbers. And I mean, there are multiple versions of, that are these numbers too high, or not so high, given the population size and things like that. So, given the population size, probably the numbers are not too high, but they are concentrated in a few urban pockets, basically the metropolitan cities, and Mumbai and Delhi, and later on in Bangalore and Chennai. So the metropolitan cities, in fact, are worst affected, and Mumbai actually still struggling with that, with the numbers. And so that is the scenario in the first couple of months, like first 4 months or so. But as I said that, because of this severe lockdown, and then what happened is that this huge, number of, people who are actually working in other states, away from their home states, suddenly they found that they have lost their jobs because of this lockdown, and they're all in what is called informal sector, and they're all these informal sector workers where even the production units are so small and tiny, they couldn't actually maintain this workforce. So the workers immediately lost their job, and they started moving back to their home. And that actually almost created almost like a kind of humanitarian tragedy, that for 2-3 days actually they just walked back home, and faced a huge sort of hardship along the way. So these kind of this problem, in fact, had further repercussions in terms of spreading the infection from urban to rural areas. Now the problem is and then we get into another problem. The problem is that if you look at the healthcare infrastructure in India, of course the overall adequacy is the problem. So overall it's not adequate. If you look at the number of doctors, for instance, the number of doctors, India as a whole, per thousand, it's even less than one, not like 0.6. So the number of doctors per thousand population, it's even less than one. Sorry, the number of beds less than one, and number of doctors even less, actually. Number of doctors, it varies. In Delhi, it is one doctor per 2,000 population. In Bihar and Madhya Pradesh, it's close to 40,000. So one doctor for one allopathy doctor for 40,000 people. Now, so it ranges like that. So in terms of number of doctors, in terms of number of hospital beds, we already have a serious inadequacy. Now, whatever we have, much of it actually is concentrated in the urban areas. Now, as the infection spreads and moves on to the rural areas, then we have this, second second phase of the crisis. That is, with even weaker infrastructure, we confront rising cases in the rural areas. Now, this is again another challenge that we are facing now. So, next, please. So this is in substance. So this is the scenario in India. Given the weak health infrastructure, it's already it's challenging in urban areas, but now it's there's because of this movement from urban to rural, we really don't know how to deal with that. But given the limited resources, the government tried to do something, and initially, actually, the strategies also changed time to time as more and more information came in, and the government also changed its strategy. Initially, the policy was to sort of quarantine the whole family. When someone gets infected, the whole family actually shifted to what is called COVID centers. But now, but later on, in fact, we found that it's not feasible at all. That so with increasing number of infections, you cannot just shift the whole family to the COVID centers, and the COVID centers also require support staff, human resources, and so all supporting infrastructure. And these COVID centers actually were not in a position to deal with this this huge crowd, which actually were immediately shifted from their home. So that's why later on the government also changed its strategy that, okay, so it's a home quarantine, in case of, if the symptom is not, severe, or, in asymptomatic cases, this home quarantine should be good enough. So then, so that is how actually gradually it's a kind of learning by doing kind of thing that the government actually exercised. Uh, so the challenges are mainly due to, I would say that it's a weak infrastructure because of underinvestment in healthcare over a long period of time. Underinvestment. Why do I say underinvestment? Because Indian government as a whole, I mean, the state government, the provincial governments, and the federal governments together spend about 1.2 to 1.6% of GDP. So it's not even 2% of GDP, less than 2% of GDP. So for long, actually, it is around 1% of GDP. Now, with 1% of GDP as government expenditure as percentage of total, percentage of GDP, it's you can imagine that actually it is one of the lowest among all the countries. So that's one issue. The second issue is that certainly in 2018, we have this new policy thrust, which actually looks at what is called demand side financing rather than strengthening the supply side. Now that, in my opinion, I think that we should rethink about this thing, because this demand side financing actually emphasizes overwhelmingly on the insurance part of it. That is, basically covering out-of-pocket expenditure, and the government felt that out-of-pocket expenditure is too high. So just to cover that, government in fact initiated this nationally funded insurance scheme. Now, I think that this kind of paradigm shift actually, in fact, further weakened the supply side focus, and that's why the government system, in fact, the primary healthcare system in the government actually has got weakened further. The third point I'd identify is that understanding of the health system as a public-private mix. What I mean by that, it's not public-private partnership that I'm talking about. I'm talking about public-private mix, in the sense that you have public sector at the same time, I mean, the publicly provided health infrastructure. At the same time, you have a kind of private sector which is almost unregulated. So that in that private sector, mostly curative, I mean, they are all curative oriented, private hospitals, basically. So, it's government, I think, needs to understand more about this, how this public-private mix works. Because in this context, we have seen that there are a lot of problems, a lot of issues actually came up, that how to deal with the private sector, because private sector, they are not forthcoming because they are profit oriented and so on and so forth. I mean, I think I have used up my time, but just I'll make the final point. So the final point is that in India, the problems are basically of this kind of threefold, but there is another fourth issue, which the next slide, please. I mean, maybe just one or two sentences. The next slide, please. Yeah. So during this pandemic, what we see is that there is another tendency in India, which might be called over centralization. That is, India is a huge country, and the federal, I mean, the health actually is in state list. Health is in state list. That means the provincial state is responsible for delivering healthcare services. And but this prevention of the extension of one state to another of infectious and contagious diseases, that's in concurrently, that is center state together. And so the center actually takes over this entire responsibility of as if the center will dictate. how to, how we can control this pandemic, but without taking the states into confidence, so to say. So that has created some problem between center and states are grumbling, and states are saying that they don't have resources. The center should give more resources to the states, but actually the states are responsible. The provincial states are responsible for delivering the services, but they don't have the resources. They don't have the money. So this is another issue actually which came up during this pandemic, which I think the government of India has to deal with in a serious manner. So I stop here. Thank you very much, and I'll come back if there are questions.
Thank you very much, Professor Chakrabarty, for the excellent presentation. So without taking much time, I just request Professor Daniel Macera to go forward with his slides. You have about 10 to 12 minutes, Professor Macera, and we come back with the question and answer, which are popped up, which will be there in the question and answer tab. Yeah, please go ahead, Professor.
Thank you, Papilla, and thank you everybody for attending to this seminar. Well, the idea of this presentation is make a short, provide some short inputs about Latin America and Argentina, the health system's performance, and considering the challenges brought by the COVID-19. Next, please. Latin America and the Caribbean are probably the most unequal region in the world. Income disparities across countries and within countries are huge, and that creates a problem to health systems performance, because decentralization and segmentation of systems between the public sector, the social insurance schemes that are covering that covers the population with formal jobs, and the private sector for the well-off population groups, makes that the coordination between one system and the other become very difficult. So the idea is try to identify what is the basic package of services that can be shared for all everywhere, regardless of income and ability to pay. So in some countries, this is not possible, and that's why the out-of-pocket expenditure as a share of the total health expenditures in health is quite high, providing a very low and poor financial protection to their population groups. Next, please. As we can see here, this is the total expenditures per capita in each of the 26 Latin American, Caribbean countries. The blue bars are the total health expenditures, and the black dots are putting together the under 5 mortality rate. What we see is the inverse correlation between how much countries spend and the results in terms of under 5 mortality rate. But on top of that, what we see is that there are still differences in performance that are related to the way the systems are organized between these 3 subsystems, as I mentioned, and the decentralization process that is quite high and deep in many countries in the region. Next, please. The segmentations create what we see in Latin America. The green countries are the ones that have a huge differentiation between what is public, what is social insurance, and what is private. That means that there are like 3 different subsystems that are covering population groups according to income and needs. There are just a few countries where the system is integrated, that are the ones we painted in yellow, that are basically the British Caribbean countries, Cuba and Costa Rica. A derivation of the segmented systems are what we call the contract intensive systems, that are the Southern Cone and Colombia in violet, and there are countries where the systems are still segmented, but there are intense relation between one system and the other in terms of contracts. Like, for instance, a social insurance institute hiring private providers or public providers to cover their populations and so on. The exception is Brazil, where we have a solo social insurance scheme, the Seguro Nacional de Salud, where the country is financing the services for about 70% of the population, and services are provided by public and also by private providers. Next, please. In the case of Argentina, Argentina is a middle high income country, and in this table what we see is the country in comparison with other group of nations with a similar healthcare expenditures per capita, measured in purchasing power parity dollars. And what we see is that Argentina, which is a federal country and very decentralized, has number of tests per 1,000 inhabitants that are very low in comparison to the rest of the nations with the same investment in health. And the cases are being growing up during the last 2 months, especially it moved from the capital city, Buenos Aires, and the Great Buenos Aires to the inner provinces. And now the core of the pandemic is outside the national capital. The lethality in terms of how many deaths over cases remains lower than the average, according to the latest numbers that we received. So what we see is that during the first period, the pandemic, the lockdown was very strict, as it was in India, as our colleagues told us a few minutes ago. And in that moment, the country had decided to invest in infrastructure, beds, intense therapy units, etc., and that allowed to reduce the lethality rate. Next, please. In terms of policy, what we see here is that the country has been invested in a different set of issues. In terms of social determinants, the government was very intense in create safety nets in terms of emergency subsidies for unemployed and poor families that allow people to survive regardless the lockdown and the loss of lots of work posts. There are tax releases for small and medium firms, and on parallel, we went through a very intense renegotiation of our national foreign debt with external bond holders and the International Monetary Fund, which is still in process. In terms of infrastructure, as I mentioned, there was significant investment in infrastructure, equipments, intense therapy units, and the allocation of human resources across the country, capacity building, and financial support from the national government to the provincial governments. In addition, the country is participating with other nations in the development of vaccines, and they have agreement with Oxford, Pfizer, and the Russian vaccine that have been developed in that country. The problem that we see in that strategy is that the test and the pool testing strategy have been very poor in comparison to the rest of the indicators, and this is an against because it's not allowing to identify the number of infected people as properly as we prefer. In terms of changes in behavior, the country had no classes at school since early March, and limited transportation just for health workers and basically, and there is a strict restriction in population mobility. The lockdown has been very long, and people were accepted the lockdown from the beginning, and during the last 2 months, 2.5 months, it was relaxed, what exposed the population to higher infection rates. Still is a pending issue, the strategy followed by the government in terms of contact tracing. There are a few instruments that have been developed to identify infected people and their close contacts, but still is a tool that has not been explored in depth, which is a problem considering that the number of infected people have been growing up, especially in inner provinces of the country. The infection rates have been going up, the deaths have been kept steady because of the investment that we as a country did at the beginning of the pandemic, but still there are equity gaps across regions in the country and cities, particularly related to income and the capacity of the provincial governments to strategize their activity plans. Next, please. Well, this is one table that comes out of a project we are doing at this very moment. The idea is to identify at the provincial level what is the level of coordination between the national Ministry of Health with the provincial Ministry of Health, the coordination across Ministry of Health at the provincial level, and with the provincial authorities to the social insurance schemes. There are different social insurance schemes in the country, and the private sector. And what we see is the set of tasks that have been undertaken by the government and the level of coordination that we have, that is the single average from 1 to 5 for a total of 14 provinces out of 24, which represent about 72.8% of the population. What we see is that the total average is 1.83 out of 5, which means that the level of coordination across subsystems and across national and subnational levels is quite low, and that has been a challenge to address the pandemic, especially in terms of managing the information across provinces and with the national government, the mobility of patients from one province to the other, and the procurement mechanisms, especially in terms of tests and medicines. Next, please. So what we found is that COVID-19 had been exposing the limitations that the healthcare system already had in the country. And this is something that we find in mostly all countries in Latin America, regardless of the political color of the government and the strategies that they were being developing. You see that Latin American countries are already in the top of the list in terms of number of infections, like Chile, Peru, Mexico, Brazil, Argentina, Colombia, Ecuador. They are all in the group of top 20 countries in terms of number of total infected people overall. And so that stressed the healthcare system and showing the need to more coordination, the need for higher priority setting mechanism and coordination across subsystems that had been a problem always, and it's been more important to identify at this moment during the pandemic. In terms of human resources, the mobility of human resources have been also the challenge, especially across provinces, and the communication and prevention campaigns promoting behavioral changes have been have been good at the beginning, and the people have been supported the lockdown, but after a few months, of course, the situation has changed, especially because during the pandemic, the number of work posts that were lost were huge, and the macroeconomic impact that we're having is enormous, with a drop of almost 20% of our GDP, according to international standards. And I'll stop here, and happy to answer questions and participate in the debate. Thank you very much.
Thank you very much, Daniel, for this excellent presentation. And now I would invite VM, Dr. VM from Palestine, to present for another 10 to 12 minutes. VM, the floor is yours.
Thank you, Papia, and thank you for all the organizers. So I'm going to reflect a bit on the response to COVID-19 in Palestine. Next slide, please. Okay, so I just wanted to give an overview of the health system. So in the occupied Palestinian territory, we're talking about the West Bank and Gaza, with a population of about 5.5 million people. We have a fairly fragmented and under-resourced health system. So there are three main providers of health services. So we have the Ministry of Health, the United Nations Relief and Works Agency for Palestinian refugees. And together, these two actually probably provide about 70 to 80% of services, and then NGOs in the private sector. And in general, I think, so thinking about the health situation in Palestine compared to other countries in the region, in general, health indicators for primary healthcare are okay, like they're good, but they haven't been improving in the same way that others have in the region. The health system has been under-resourced. So if we think about national expenditure on health in terms of official government expenditure, on health, it's very low, with about 5 or 6% of the national budget, with a lot more emphasis on security in the national budget. The other key issue is that even though about 80% of the population is covered by some sort of health insurance, whether it's from the Ministry of Health or private sector, out-of-pocket expenditure is very high, with about 40% of expenditure on health, with 40% of health expenditure being out of pocket. And this is a main issue, and one of the main sources of out-of-pocket expenditure is actually on drug expenditure, which is one of the areas where there's a chronic shortage in the health system. There's also the additional layer of vulnerability due to the conflict and structural fragility. So in the West Bank and Gaza, there's been occupation since 1967. What that means is that and then up until 1994, with the signing of the peace accords, and that was when the Palestinian Authority came to be. And so the Palestinian Authority is actually responsible for healthcare, but at the same time, there are structural constraints and others that severely restrain this, and this actually has played out in COVID. So for example, the Palestinian Authority doesn't have any sovereignty over borders. It can't control what comes in and out, and there are various agreements that also limit the type of raw materials and equipment that are allowed into the West Bank and Gaza. This has played out importantly in health, because it also, so certain equipment like radiotherapy equipments are banned from entering the West Bank and Gaza. So those have to actually, so any patients requiring these kinds of treatments need to then be referred to hospitals in East Jerusalem or in Israel or Jordan. And what that has meant for the already insufficient budget for healthcare is that about 37% of the budget actually goes to cover these referrals outside of the public health system. The other issue is that there's also a series of movement restrictions and mobility restrictions, and then other constraints on sovereignty even within the West Bank and Gaza, which is classified into three types of areas. So the Palestinian Authority only really can control or has control over civil and security issues in about 20% of the West Bank, and doesn't have control over civil and security issues in about 60% of the West Bank. So this has actually also played out importantly, and I'll talk about that in a bit. Initially, we were watching the situation closely in terms of the global COVID situation. We didn't actually have our first cases until early March, and right after the first cases were confirmed in Bethlehem, Bethlehem and neighboring areas were completely locked down, and then there was a state of emergency was declared, and then a wider scale lockdown. And it was a very strict and swift lockdown, and the main justification for the measures that were taken into place was that the health system is too fragile to actually cope with the kind of epidemic that we were seeing internationally, especially with the data that was coming out of Italy and the UK at the time. So all of the projections were expecting that if we had a similar outbreak, the system would not be able to cope. So that was the justification. So that initial strict lockdown lasted for about 3 months, like from the beginning of March until the end of May. And in the beginning, there were some early signs of collaboration between different sectors, especially between the Ministry of Health and the security sector in order to implement some of the protocols and guidelines. There was some coordination also between the Ministry of Health and the Ministry of Social Development, or social, which was responsible also for limited social protection schemes. But then, given also the resource constraints and some developments in the political situation, where the Palestinian Authority also wasn't able to access funds that were supposed to be transferred to them by the Israeli authorities, they weren't actually able to provide any sort of protection or enough financial coverage during this time. So there was eventually a lot of pushback from the population and resistance to ongoing lockdown, especially without any sort of provisions that were provided by the government. There was at this time local organizations, some like charity organizations that did step in and tried to fill some of that gap, but it became very clear, and recent data also from a national survey actually shows that 42% of households during this initial lockdown lost at least 50% of their income or more. So the financial fallout of the lockdown was significant, and the government was not actually able to provide an alternative. And what that ended up leading to was there was a lot of pushback, and initially the Ministry of Health had a gradual plan for how the eventual opening would happen, but what ended up happening on the ground was that everything opened suddenly, and that was primarily because of protest from the population. Actually, can we go to the next slide and then come back here? And then what that led to eventually was, so if we look at that period from March to May, we had a very controlled situation with less than 1,000 cases, and in terms of the cumulative case count. And then we had that sudden opening at the end of May, beginning of June. And then at the end of June, beginning of July, that was when they discovered a cluster outbreak in one of the districts in the south of the West Bank, and the Hebron district. And what that actually signified was that there were significant gaps in testing. And during this time, the Ministry of Health was trying to procure additional testing and other resources, but we're not able to actually get them in through borders, because at that time there were also problems between the Palestinian Authority and the Israeli government. And so so this cluster of there was a cluster in the south of the West Bank, but there were various clusters of outbreaks that were mainly traced back to weddings and other social gatherings that had been happening, especially in rural areas where the Palestinian Authority didn't really have jurisdiction to actually have security personnel on the ground to enforce the lockdown or even enforce measures. And so, and that was when we started to see this jump in cases, and then eventually led to the situation that we actually have right now, which is a situation where we have community spread. And one thing I forgot to mention was initially the first cases that were confirmed were traced back to people who interacted with tourists that were visiting Bethlehem. So at that point, and for the duration of the lockdown, there weren't really cases of community transmission. The primary cases were either people within that circle or workers that had worked in Israel, that were working in Israel. But at this point, there's wide community spread. The tracing has become a lot more difficult. We've also faced different points in time where we've had shortages in testing material and testing supply. And a lot of that also goes back to the political situation and the lack of control over borders. And if we look a bit at the cases now, so within this period, we're now, I mean, this was as of the 29th of October, and this has actually increased to about 67,000 confirmed cases. Most of them are in the West Bank, but what's significant here is that in the Gaza Strip, which had a much more contained situation, only recently had this a sudden surge that was traced back to people that had actually entered Jerusalem and the rest of the West Bank, but then there were no control in terms of testing on the way back. So there were different pockets that eventually led to some community spread, although it is more limited than the situation we have in the West Bank. But it's more worrisome because of the living conditions and constraints in the Gaza Strip at the moment. Most of the cases have recovered, but but there is generally consensus among local experts that these are probably underestimates, and that goes back again to the shortages in testing. So compared to even other countries in the region, like Jordan, our cumulative test count up to this point is about 500,000 compared to almost 2 million in Jordan, and 2 million in Lebanon, and in Israel it's also they have much wider testing capacity. So that's also limited the possibility for predicting how, or even identifying where these outbreaks were actually happening. The death count has also increased. It's still not a high case fatality rate, but it has increased substantially in the last few months. Especially it was at around 0.5% until about August, and now it's it's close to the 1% mark. And we are seeing more cases of health workers actually getting infected with COVID. So the situation overall has, went from a fairly controlled situation to one of that's where the officials have really lost control. And if we go to the next slide. So this is just if we can look at the case count per day. Next slide, please. And they've lost control, and like I mentioned, so part of it goes back to the political context and the structural constraints, especially with limitations on sovereignty. And ability to control borders, which has really affected procurement, and it's also affected implementation of protocols. But the other thing that it's actually revealed was also pre-existing underinvestment in social services, including healthcare and other social protection mechanisms. So between the national budget for health and then for other forms of social protection, it's still less than 10% of spending, which is inadequate. And that's been one of the main areas, especially with the economic fallout, that's been one of the main areas that's really affected adherence and the ability of the government to even try to institute a new lockdown. Anytime that's been put on the table, it's been heavily resisted, and primarily going back to these economic constraints. And in the last couple of months, the government's ability to meet their responsibilities even towards their own employees have been severely limited, where public employees have only received half of their salaries in the last 4 or 5 months. So what that's revealed is that there really needs to be more investment in these social institutions. There need to be better linkages between the various sectors, also governmental and non-governmental sectors. There's more limited, even coordination within the health sector has also been limited across the different providers, and that's been also one of the limitations in terms of the adequacy or the effectiveness of the response. And the other key areas that we need enhanced and integrated information systems. So which are important for like contact tracing, but also important of keeping track of the epidemiological situation. And now one of the fears is because a lot of the resources that were already quite limited have been reallocated to the COVID response at the expense of other services. We actually don't know what the longer term fallout will be in terms of health service access and also health conditions. And if we just go to the next slide. And, you know, thinking in terms of the global health agendas and universal health coverage, the experience here has also just confirmed how important it is to think in terms of the whole society response, and also which prioritizes universal health coverage and integrated health systems within larger social protection mechanisms. And also addressing inequities and inequalities in global health. And one of the main issues is, you know, in resource constrained environments like Palestine, one of the main issues now is also in terms of access to resources like testing equipment, but then even with talk of a vaccine being developed, how are these decisions in terms of allocation and procurement going to be implemented, and how can we better also address inequalities in healthcare through better health governance mechanisms. And I'll end here and look forward to questions.
Hi, thank you very much, VM. Thank you, all of you, Professor Chakrabarty, Daniel Mesera. So I have two questions here in the Q&A for Dr. Chakrabarty. One is for VM. The daily cases of mortality. And the question was, how do you know that this has been attributed by COVID and not anything else? How confident you were? So would you like to respond to that?
Yeah, it's a good question. In fact, all of us are grappling with that, and our hunch is that you know, the number of deaths and number of cases all are underestimated, and because the testing is low compared to you know, the international standard. You know, but if you count this number of testing per 1,000 population, it's pretty low. So if we tested more, probably we would have more cases. And death. The other issue is that comorbidities. The comorbidities, it's a very you know, complex issue that, you know, whether it's but you know, I mean, the government has developed standard protocol to identify whether it's due to COVID or whether it's due to comorbidities. So by that criteria, we get these numbers. But you're right, absolutely right. This is thoroughly underestimated. I think many of us will feel that. Probably, you know, it's COVID case, but it's counted as something else. So that may happen.
Okay, the second question I think was related to comorbidity. When you say that the case positivity rate was quite high,
Yes.
whereas India showed, you know, in terms of proportion of death was quite low. So the question is that, do you think that certain comorbidity issues might explain that why India had low mortality due to COVID?
One issue is demography. I mean, like, you know, this because of this, you know, large higher proportion of the young among the infected. And I mean, because of the demographic sort of composition. So, and since older people are more vulnerable to COVID, so that's why I think this recovery rate is relatively high because of these younger people getting infected. But I looked at the data. It looks like that the fatality actually is not the highest among the 60 plus, but it is among the around this 45 to 60. That age group actually the fatality is very high. Yeah. But we don't know the reason for that and why is it so. But you are right. I mean, the question is very good actually. That yeah, this is probably the case, but we don't have clear on that.
So I think there is a question for Professor Macera, and it talks about that how the process indicators for lockdown, so for example, adherence to lockdown have been measured. And do you have a data for that in case of Argentina?
Yes. Yeah, there is no public information about those numbers, but at the private sector, we have been working with that based on, well, as everybody with Google Maps and the attendance to parks and works and workplaces or staying at home. And on top of that, we have access as part of the think tank where I belong. We have been working with data sets coming from cellular phones and application for cellular phones. And we have been saying that the lockdown now in some places are recovering the same levels that we have in March, and particularly in the inner cities and the inner provinces. And so in general, the level of respect of the lockdown was very high at the beginning. And then based on this information, it was relaxed. And there is an issue there that there is under study, not just in Argentina, but in many other places, is if lockdown has been effective in reducing the rate of infection, because the people perhaps are not going out, but they prefer to stay at home, and they organize private meetings, and then the rate of infection goes up, despite the fact that are not moving around. Over to you.
Thank you very much, Dr. Macera. I think there is another two questions, and I guess that this is not specifically for anyone, but all of you can respond to that. So one participant is asking that in developed country scenarios, we have a lot of churches and charities who provide health services. So is it the same in your context? And if yes, then what has been the role? So Daniel, would you like to go forward? And then I move on to BM and then maybe Dr. Chakraborty.
Yes, well, at least in Argentina, the room for charities and NGOs providing services is quite low. In general, what happens is that these institutions are more on the research and advocacy side. And in that sense, they have been very active in terms of providing information, studies, and actually there are a group of institutions that have been that were advising the Ministry of Health and the President himself. So in that sense, the role of the civil society has been enormous and very exposed to through the media. But the provision, in the provision of service side, it was, at least in Argentina, is relatively low in comparison to other regions like Africa and Asia, where I know that the role of charities, for instance, are quite important. Over.
VM, can I request you to respond to this question? Should I repeat it for you once more?
No, I have it.
Okay.
Yeah, so I think in terms of the role of charities, so there are some charities within like the NGOs that I mentioned in the health system. So one of the main ones was was the Palestinian Red Crescent Society, which has played a role with like ambulance care and other things. Um, Otherwise, charities have been more involved in meeting other needs in terms of like food packages, some other assistance, but that really, it was on a much larger scale initially, but it has waned off a bit since the initial period.
Thank you very much. Professor Chakrabarti, would you like to have a
Uh,
response?
Yeah, I think it's similar to what Daniel said, that in the Indian context we have a few very good curative care facilities run by missionaries and non-profit basis. And but our problem is that we don't have good data on non-government sector. So the entire non-government sector, it's clubbed as the private sector, and so there are non-profit sector, there are for-profit sector, facilities, all kinds of things are there. But we don't have enough data to say anything concrete about this private or non-government sector. And I'm sure that there are good curative care facilities in India, and we know them well. And but again, in terms of percentage or proportion, they can serve. It's very little. I mean, compared to the huge population of India.
Yeah. Thank you very much. So I think there is another question which has just come up, and it's a very important question. It's asking about what is the role of lay health workers in various LMICs context combating COVID situations. So Daniel, would you like to go forward with this response on lay health workers? Do you see a role in Argentinian context?
I'm sorry, the role of what? I'm sorry.
Lay health workers who are not supposed to have the formal health education or any kind of training. So do you have anything in your health workforce who could be termed as lay health workers?
Oh, no, I don't see much. Yeah, I probably we don't have information enough to identify the role of these groups, but if they have it, it's not very strong. Sorry.
Okay, all right. Professor Chakrabarti, I know in India, lay health workers are quite like, barefoot doctors, we call them many times. We call like rural health professionals. So,
yeah. Actually, we have two different kinds of health workers. I mean, one is which government has supported that kind of system in the rural areas, particularly, which we call accredited health workers, that ASHA. I mean, their basic role is to identify the households where people have some conditions or something, and there's very good support in the rural areas. But since, as I said, that since primarily it is in urban areas now, I mean, so far, and now it's slowly spreading to rural areas as well. So of course, these health workers actually can help in identifying places of concentration of infection. But in rural areas, actually, we don't have that kind of workers. But besides that, I think that we have, I mean, during this time, one good thing is that there are a lot of civil society support groups which actually have come up, and it may be a kind of group of doctors with some other volunteers, and they in fact provide a lot of help in terms of dissemination of information, and how you should quarantine and things like that. So I think that these support groups actually, they are doing good job in India and in many places. But still, I mean, given the size of the country, again, it's not much. But we should appreciate the this kind of support group. It's a kind of voluntary support groups which have actually come up from various people who are connected with health system. Thank you.
Thank you. VM, there is a question for you. This is about, somebody is asking that with high financial stress, which should be addressed first in case of Palestine, public health capacity, doctor and hospitals, for example, or general well-being like water, sanitation, hygiene, which can which in long term can help public health. So we would like your response on it, VM. Should I repeat?
I think I got it.
Okay.
So I think yeah. So I think it's maybe a combination. Some area there is actually quite a lot of inequality between areas in terms of even basic infrastructure and hygiene. So some areas, especially in the Jordan Valley, really do need that kind of investment. One of the other issues, like I mentioned, because there is a lot of outsourcing of services that are not where the public sector is not able to provide them, and that actually takes up a huge amount of the budget. So one of the moves right now is looking towards nationalizing some of those within pre-existing services, which would require actually increasing resources within the Ministry of Health, but that would eventually cut down on some of the costs in referrals and other systems.
Yeah, thank you very much. And I think we have another questions. It's about information campaigns. So the person is asking that what is the role of information campaigns? Are there linguistic issues in your country? It's a very interesting questions. And any of one of you, Daniel, you have unmuted yourself. Would you like to go ahead first?
Yes, thank you. Yeah, in Argentina, the communication, the information campaigns are very, very strong and widespread. And at least during the first 3 months of the pandemic, every 2 weeks, there was a message to the nation from the president of the country himself. And in the same table, there was the mayor of the city of Buenos Aires and the governor of the province. And they were both from different political parties, and there was like a very constructive message to the people that regardless the political party they belong to, they were able to have a common message and coordination between them in different jurisdictions, and that has been very good. Has been a problem with the mass media. In many cases, journalists are using politically the pandemic to bring issues against or pro the government, and they are creating some confusion. And that, I think that is a huge debate that us as a society need to read to ourselves in terms of how to use a powerful tool as communication in general media at the national provincial level to improve the dialogue and to create awareness and not confusion. Over to you.
Thank you very much. And I think there is one question to Dr. Achin Chakrabarty. Do some population in India rely on traditional medicine such as plants, hoping that they can treat COVID? Would you like to respond to that?
Oh, sure. I mean, you're right. I mean, there are all kinds of, preferences that you could see that, people exercise. And so, there's something called traditional medicine in India, and government also recognizes it, and apart from allopathic system. But in terms of preference, look at the surveys, people, in fact, I mean, the overwhelming majority actually prefer allopathic medicine. I mean, no doubt about it. So these traditional medicines, I mean, very, it's a small minority actually prefer to go for traditional medicines. And second is that, and people have good knowledge about that, for certain conditions, actually, they could be effective. But, since there is no effective cure for COVID and people are still groping in the dark, so, in this process of groping, you pick up some plants as well. And so apart from all those, medicines which are prescribed. You're absolutely right that people have this variety of preferences in terms of as far as the traditional medicines are concerned. But so far, I don't know that any traditional practitioners actually is claiming. I mean, there may be one or two traditional doctors claiming that I have the cure, but I don't think that people are taking them seriously. Okay.
Yeah,
Thank
I
you.
think there is another question for India. It's about like multilingual,
Yeah.
whether this is creating any problem or.
As I said that this I mean since it is constitutionally sort of specified that the health issues are the provincial states domain. So provincial states basically the provincial states are were formed actually on a linguistic basis. So the majority of them speak one language. So that's one. But the linguistic problem probably it's less in India because as far as this information is concerned, actually they're multilingual material that you can see that so the governments actually produce in different languages, targeting different linguistic groups. So I think that language may not be an issue. Interestingly, I mean, there's a very good study actually by this MIT Poverty Action Lab group that Abhijit Vinayak Banerjee and his colleagues in the West Bengal state in India. And they looked at this particular issue of this information dissemination. And they find that, if the information is disseminated through these, well-known public figures, I mean, well-known public figures, maybe they have excelled in this or that, then its impact actually is more. I mean, so they could actually quantify that, the impact when you spread the information through some public figures. So there are people have been looking into that how and why some messages become effective and some messages are. So linguistic issues, I think that it's not very serious in that particular context because we have this multiple language kind of material. So
Thank you very much. I think VM, there is a question for everyone, but I think we'll like to get your response on this first. And this is about looking forward. What intervention or changes are needed in health systems in Palestine to be better prepared for future pandemics, as it is predicted that we will see more of these in medium to long-term future? That really feels scary. But would you have some response to it?
Yeah, I think one of the main things is increasing investment in the health system and working on linkages between different providers within the broader health system. So that fragmentation has really disadvantaged the response. And then I think overall working towards a universal health coverage that's well integrated within a larger social protection scheme.
Okay, so any final views on these, how we prepare? Daniel, from you?
Yes, thank you. I think that what we were saying about the path to universal health coverage is key, particularly in countries like ours and mostly all low and middle income countries where the systems are quite segmented. The demand for coordination is huge, and that includes how to manage information systems, how to coordinate the capacity enhancing of health workers in terms of preventive care and communication. And we have to take advantage of this as specialists in health systems research because unfortunately, COVID put located health in the top of the agenda, and this is a moment to start thinking about structural reforms that need to be done in order to be better prepared, hopefully not, for the next event like this. Thank you.
Thank you very much. We are really end of our 1.5 hour session. But Professor Chakrabarty, would you have just half a second's response to how we prepare in India? And somebody
Well, I mean,
yeah,
I mean, this is very clear. I mean, at least one lesson that we learned from this pandemic is that we have to strengthen the public health system as the provider. I mean, there is no other way. The public health system as the primary provider of promotive, preventive, and curative services. Now, so that's the base, that's the foundation. And on that foundation, then we can move on to, all kinds of, finer fine tuning with private sector and all these things. But that base actually we should not weaken. I mean, that's something that I think that we have learned from this pandemic experience.
Thank you very much, all of you today. And I think we have generated interest among our audiences and a lot of questions. These are really showing up that, the information that you brought in really got very well kind of, heard. And I think you made it so clear that I mean, talking about summing up, we have the problem of weak health infrastructure, and it just reflected all across your presentations. You talked about a lack of investment, public investments in health, which probably for Palestine, it's going somewhere else. And also a layer of extra layer of challenge for Palestine is definitely the lack of control of the country's government on several of these issues. We have to invest in public health there could be no option for that. And going ahead, if we are trying to prepare ourselves for another wave or surge of this kind of pandemic situations, I think we have to keep this universal health coverage very well in mind, because we are already running a very difficult situation due to the economic inequity issues in those countries, in those economies. And capacities of healthcare workers, especially like how to contain, how to prevent, as you said, Professor Chakrabarty, Professor Merceravium, all of you, that all these three components of health service, like preventive, promotive, and curative, has to be through public health systems. There is no other alternative. The challenge remains, how do we do that? So we really thank you on behalf of IGDC and University of York. We thank all of you, all of our panelists and the audiences to join us for today. And I hand over these to Jessica now for conclusion. Thank you very much.
Thank you, Papia, for a very interesting session, and thank you for our guests today. So just to wrap up, we're very happy that you joined us for this session. We're welcoming you for our next one, which is, I'm really excited about our next session, which will be on Wednesday, 11th of November at 4 p.m. And this one will be a session on migration, migrants and refugees during COVID-19 in the UK and globally. And it will be a session that will be hosted for the Festival of Social Sciences, the ESRC Festival of Social Sciences. And it will be IGDC co-hosting it in partnership with the University of York's Migration Network. And so if you're interested in things related to migration, asylum, seekers, refugees, both in the UK and globally, please do come up, join us. And Dr. Sarah De Jong will be chairing this session with a very excellent list of speakers. So please go on to our IGDC webpage and sign up for the session, but also if you know anyone who would be interested in these things, please do join us. And so thank you very much for attending today's sessions. And so looking forward to seeing you next time. Bye.
Thank you very much.
Thank you.
Thank you.
Bye-bye.
Thank you.